The number that almost killed him was not 180. It was not 160. It was not even the 140 over 90 threshold that every chart in every doctor's office in the country has drilled into your memory as the danger line. The number that put a 73-year-old retired schoolteacher in the back of an ambulance on a Saturday morning was 62, not his systolic, his diastolic. The bottom number, the one your doctor glances at, the one printed in smaller font on every blood pressure reading, the one that nobody has ever sat you down and explained, could be just as lethal as a number that is too high. His systolic was 155. His doctor had been focused on bringing that top number down for years. More medication, higher doses, and it was working. The systolic dropped, the chart looked better. But while everyone watched the top number fall, nobody noticed that the bottom number had been quietly falling with it, sinking past 70, past 65, settling into a range that was slowly starving his heart of the blood it needed to survive. On that Saturday morning, his heart told him what his blood pressure monitor never did. I am Dr. Arya, and on this channel, Senior Health, I focus on the health realities that matter most after 60, particularly the ones hidden inside numbers you think you understand. Today I am going to talk about a blood pressure number that is putting millions of older adults in danger, and it is not the number you have been warned about your entire life. It is not the top number climbing too high. It is the bottom number dropping too low. And if you are over 60 and you are currently on blood pressure medication, what I'm about to explain could fundamentally change how you understand the readings you see on your home monitor every morning. Let me first explain what that bottom number actually means, because most people have never been given a clear explanation. When your blood pressure is measured, two numbers appear. The top number, systolic, represents the pressure inside your arteries when your heart contracts and pushes blood outward. That is the moment of maximum force. The bottom number, diastolic, represents the pressure inside your arteries when your heart relaxes between beats. That is the moment when your heart itself receives its own blood supply. Read that again because it is the single most important sentence in this entire video. Your heart muscle receives its blood supply during diastole, during the relaxation phase, when the bottom number determines how much pressure is available to push blood through the coronary arteries and into the heart tissue itself. When that bottom number is robust, when diastolic pressure is adequate, your heart fills with the oxygen-rich blood it needs to keep beating effectively. When that bottom number drops too low, the driving pressure behind coronary blood flow diminishes. Your heart is still beating. It is still pumping blood to the rest of your body. But it is being slowly, quietly deprived of the blood it needs for itself. The organ responsible for keeping you alive is being starved in the very moment it is supposed to be refueling. This is not theoretical. A landmark study published in the Journal of the American College of Cardiology examined outcomes in over 11,000 adults with coronary artery disease and found a clear and alarming pattern. Patients whose diastolic blood pressure dropped below 70 millimeters of mercury had a significantly increased risk of heart attack, and patients whose diastolic dropped below 60 had a risk that was dramatically higher still. The relationship was not linear. It followed what researchers call a J-curve, meaning that risk did not simply decrease as blood pressure went lower. Risk decreased to a point and then it reversed sharply. It began climbing again once diastolic pressure fell below the threshold the heart needed to perfuse itself adequately. The J-curve. Remember that term because it is the single most important concept in blood pressure management for older adults that almost nobody is talking about. For decades, the entire conversation around blood pressure has been framed as a one-directional problem. High is dangerous. Lower is better. Get the numbers down. The lower you go, the safer you are. That framing made sense when it was applied to younger adults with flexible arteries and strong hearts, people whose bodies could tolerate very low pressures without any compromise in organ perfusion. But after 60, the game changes fundamentally, and the one-directional model becomes not just incomplete, but actively dangerous. Here is why. As you age, your large arteries stiffen. This is a universal, unavoidable biological process. When arteries stiffen, systolic pressure naturally rises because the rigid vessels cannot absorb the force of each heartbeat the way they once did. At the same time, and this is the part most people are never told, diastolic pressure naturally falls. Stiff arteries recoil less effectively during the relaxation phase, so the baseline pressure between beats drops. This means that the gap between your systolic and diastolic numbers, known as your pulse pressure, naturally widens with age. It is common and even expected for a person in their 70s to have a reading like 150 over 65 or 155 over 62. The top number is elevated, the bottom number is low, and the gap between them is wide. Now here is where the danger enters. Your doctor sees that systolic reading of 150 or 155 and does exactly what guidelines tell them to do. They increase your medication to bring it down. The drugs work. The systolic falls, but the medications that lower systolic pressure also lower diastolic pressure. There is no drug that selectively reduces only the top number while leaving the bottom number untouched. They both come down together. So while the systolic drops from 105 to 135, a change that looks like progress, the diastolic drops from 65 to 55, a change that looks like nothing on a chart but feels like everything inside your coronary arteries. Your doctor sees a better systolic number and is satisfied. Your heart sees a diastolic number that can no longer sustain adequate coronary blood flow and begins to suffer. This is the paradox at the center of blood pressure treatment in older adults, and it is one that medicine has been extraordinarily slow to confront openly. Treating the top number aggressively can inadvertently push the bottom number into a range that damages the very organ the treatment was designed to protect. The medication lowers risk from one direction while increasing it from another, and because the danger of low diastolic pressure is less dramatic, less visible, and far less embedded in public awareness than the danger of high systolic pressure, it goes unrecognized in millions of patients. Let me ask you something right now. Do you know your diastolic number, not your systolic? You probably know that one by heart. Your doctor mentions it at every visit. It is the number that gets circled, discussed, medicated. But do you know the bottom number? Could you tell me right now what it was at your last reading? And more importantly, has any physician ever told you that there is a floor below which that number should not go? If the answer is no, you are in the majority, and that needs to change today. Here is what I want you to understand about diastolic ranges after the age of 60. Research consistently suggests that a diastolic pressure between 70 and 80 is where cardiovascular outcomes are best for older adults. Above 90, risk increases from the hypertensive stress that high diastolic pressure places on the vessel walls. But below 60, risk increases from inadequate coronary perfusion, poor organ blood flow, and the cascade of symptoms that accompany a body that is not receiving enough pressure to distribute blood where it needs to go. Between 60 and 70 is a monitoring zone, a range where vigilance is warranted and where symptoms should be tracked carefully. Below 60 is a red flag that demands a conversation with your physician, a medication review, and possibly a change in your treatment plan. Let me describe what low diastolic pressure feels like in daily life, because these symptoms are so commonly misattributed to aging that most people never connect them to their blood pressure at all. Fatigue that seems to come from nowhere and does not improve with rest. Lightheadedness when you stand, particularly in the morning. A vague sense of weakness or heaviness in your body that you cannot explain. Episodes where your vision dims briefly or the world feels unsteady for a few seconds. Difficulty concentrating, a mental cloudiness that settles over your thinking like a fog that will not lift. And in some cases, chest discomfort, not the dramatic crushing pain of a television heart attack, but a subtle tightness or pressure that comes and goes, particularly during exertion, and that you have probably dismissed as indigestion or muscle strain. Every one of those symptoms can be a sign that your diastolic pressure is too low and your heart is not receiving adequate blood flow during its resting phase. Every one of them is routinely explained away as normal aging, and every one of them is potentially reversible with a medication adjustment that addresses the bottom number instead of exclusively chasing the top one. I want to give you something concrete to do this week because information without action changes nothing. First, if you have a home blood pressure monitor, and every person over 60 should, start recording both numbers at every reading, not just the top number, both. Write them down, date them, track the diastolic specifically. If you see it consistently sitting below 65, and especially if it is sitting below 60, you have data that your doctor needs to see. Second, the next time you measure your blood pressure, calculate your pulse pressure. Take the top number and subtract the bottom number. If the result is greater than 60, that wide gap indicates significant arterial stiffness and suggests that aggressive systolic lowering may carry the risk of pushing your diastolic into a dangerous range. This is a number worth discussing with your physician. Third, bring your recorded numbers to your next doctor's visit and ask one specific question. Given my diastolic readings, is my current medication plan accounting for the risk of low diastolic pressure, or are we focused exclusively on the systolic number? That single question opens a door that most appointments never walk through. It tells your doctor that you understand the J-curve, that you are watching the bottom number, and that you expect your treatment to protect both sides of the equation. There is a broader truth embedded in everything I have shared today, and it is this. Blood pressure management after 60 is not a simple math problem with one direction. It is a balancing act. The goal is not the lowest possible number. The goal is the right number, the range where your systolic is controlled enough to protect your vessels and your diastolic is preserved enough to protect your heart. Those two goals can conflict, and when they do, the resolution requires nuance, individualization, and a physician who understands that your 74-year-old body does not play by the same rules as the 50-year-old body that most guidelines were written for. The man from the beginning of this video survived. He was fortunate. His heart attack was caught early and treated quickly, but when his cardiologist reviewed his records afterward, the pattern was undeniable. His diastolic pressure had been declining steadily for 14 months. It had crossed below 65 7 months before the event. It had dropped below 60 3 months before. Every reading was documented. Every reading was in the chart. And not once during those 14 months had anyone flagged the bottom number as a concern, because every eye in the room was fixed on the top number coming down. And that is all anyone was trained to watch. He did not need more medication. He needed someone to look at the whole reading, both numbers, the full picture. And he needed that 14 months before he ended up in an ambulance, not 3 days after. You have the ability right now to be ahead of that timeline. You have a monitor. You have a pen. You have the knowledge you did not have 10 minutes ago. Use all three. If this changed how you think about your blood pressure reading, share this video with someone over 60 who checks their blood pressure regularly but has never paid attention to the bottom number. That awareness could be the thing that keeps them safe. Subscribe to this channel because next week we are going to talk about why your resting heart rate after 65 matters more than almost any other number your doctor measures and what the ideal range actually is for your age. Everything I have shared today is based on current cardiovascular research and my clinical experience, but it is general health education, not personal medical advice. Your blood pressure targets should be determined in partnership with your physician based on your complete medical history, your current medications, and your individual risk profile. Do not change your medication based on this video alone. Use it to start a conversation that could change your care for the better. That is where the real protection begins. Take care of yourselves.